insomnia or sleep disturbances. In this talk, I'll be tackling the following points. First, I'll be defining insomnia, what is insomnia, prevalence, types, acute and chronic, and what are the consequences of insomnia. It is very nice to give the talk about insomnia just at the end of the day, so somebody who wants to sleep, he will sleep very well. We'll give you an up-to-date information on insomnia, role of family physician in recognizing and managing insomnia, pharmacological and behavioral therapy, and then we'll touch a little bit on antidepressant, antihistamine, melatonin, and other drugs that are used for treating insomnia. The definition, we have two definitions in this lecture. The first definition, insomnia is a subjective condition of insufficient or non-restorative sleep despite an adequate opportunity to sleep. You want to go to sleep, but you cannot go to sleep. You cannot go to deep sleep. This is one definition. Another definition is an experience of inadequate or poor quality sleep characterized by one or more of the following. Either difficulty falling asleep. Some of us experience this when you go to bed, for example, at 10 o'clock. You will go to sleep only at 11 or 12, though you are in bed since 10 o'clock. So difficulty falling asleep, and then difficulty maintaining sleep, and this usually seen with the old people, like myself. At the middle of the night, we wake up, we don't know what to do. Waking up too early in the morning, and this is also with the old people, they wake up too early in the morning, for example, 3, 4 o'clock in the morning. Fortunately, our people, they wake up to pray, but other people, they don't know what to do. And the fourth way is a non-refreshing sleep. In the morning, when you ask him, he said, yes, I slept last night, but I feel I did not have a good sleep. So these are different types of insomnia. Why are we interested in insomnia? Why the lecture about insomnia this morning? Because we have 1/3 of our patients seen in the primary care experience some difficulties in sleeping. And 10% of patients have chronic sleep problem. However, it is not the main complaint at the primary care setting, but 30 to 40% of adults experience some level of insomnia within any given year. Any of us in this audience did not experience insomnia? Did not experience insomnia? None of us. So all of us has experienced insomnia sometime in their life, okay? Changes in sleep, in the elderly, they require a longer time to fall asleep, so we increase the latency. The young subjects spend 19% of total sleep in deep stages, compared to only 10% of middle ages, 40 to 59, and only 5 to 7% in older people. Okay? The etiology, they think that duration of insomnia is important. We have the transient, of course we'll speak about two different things. First, the transient insomnia, which is insomnia that is less than few nights, and short term, which is insomnia of less than 3 weeks, and these two occur in the absence of sleep abnormalities. When it comes to the long term, this is the more than 3 weeks associated with other conditions. And we will have another categorization of insomnia, which is the acute and the chronic. I'll speak about it shortly. Then we have the initial insomnia, difficulty falling asleep, result from emotional disturbances. For example, if you just had a result of the exam today, and it is not a very good result, so you will not go to sleep easily tonight. So another categorization is the acute and the chronic insomnia. The acute is a period of sleep difficulty lasting one night in a few weeks. So if the patient complains that he cannot sleep at least one night in a few weeks, this is only acute. But when it comes to the chronic, it is a period of sleep difficulty lasting 3 nights per week for 1 month or more. So if the patient complains of insomnia of 3 nights per week, or at least 1 month or more, then we are talking about chronic insomnia. Why is it important to categorize to acute and chronic? This is important for the management. The acute insomnia, it is caused often by an emotional, physical discomfort. For example, significant life stress, somebody had bad news or had an accident or anything, then he will not go to sleep that night, which is acute. Or acute illness, if somebody had flu or any acute illness, he will not go to sleep. Environmental disturbances, if your neighbor is enjoying the night of the year with the high music, noise, or somebody in the road, maintaining the road with the use of the compression all the night, he will not have good sleep, like which we had in Ramadan. Some people, they like to sleep at Ramadan, but other people would like to work at Ramadan. This is very difficult. I had it this Ramadan. My neighbor was using compression at night. compression اللي هو اللي يحفر الصدر all night. لأنه جاره اللي جنبه قال له ما تشتغل في النهار. لازم تشتغل في الليل. فأنا تضررت لأني أنا بنام في الليل. عنده جارين، جار بينام في الليل. جيت لاج، أعتقد معظمكم يعرف الجيت لاج. This is when you travel from the east to the west, you find difficulty maintaining sleep because, for example, in the west it is night now, where in here it is day. When you come to talk about the chronic insomnia, it is usually associated with medical condition. For example, if the patient is in pain, he will not go to sleep, or immobility, or difficulty breathing. If he cannot breathe, he will not go to sleep. Or if he is dementic, or if there is a hormonal change in pregnancy, for example, or pre-menopause and menopause. These are all the conditions associated with chronic insomnia. Gastroesophageal reflux, this will cause a chronic insomnia. So this is the chronic insomnia. Also, chronic insomnia caused by many different factors in conjunction with other health problems. For example, psychiatric disorder. And it is said that psychiatric disorder account for less than 50% of chronic insomnia. For example, conditions like mood and anxiety. These are mainly associated with chronic insomnia. The patient is depressed or anxious and not go to sleep. So this is chronic insomnia associated with psychiatric disorder. Another condition is medication and substance use. For example, those who are using the heroin, the cocaine, or other stimulant. Depending on the dose, lipid solubility of the drug, individual variation. Stimulating antidepressant or caffeine, this can lead to chronic insomnia. Steroids, decongestant, beta blocker, alcohol, nicotine, all these can lead to, the chronic use of all of these can lead to chronic insomnia. A specific sleep disorder, this is another problem, which is, there are 4 conditions in this case: the restless leg syndrome, syndrome called restless leg syndrome, periodic limb movement disorder, sleep apnea, and circadian rhythm sleep disorder. We'll talk a little bit about each one of these. And the restless leg syndrome, which is common in the old, it is an unpleasant sensation in the legs or feet that are temporarily relieved by moving the limbs at night and while lying down. The other condition, the periodic limb movement disorder, again it is common in the old. It is characterized by bilateral repeated rhythmic small amplitude jerking or twitching movement in the lower extremities and less frequently in the arms. These movements occur every 20 to 90 seconds and can lead to arousal, usually not perceived by the patient, but the problem is the spouse. Patient report that sleep is not refreshing. This is the only thing the patient reports to you. The partner usually report the condition. For example, the wife or the husband, he will feel the movement. Every 20 to 90 seconds, the patient will move his leg. This is we call the periodic limb movement disorder. We move to the obstructive sleep apnea, occasionally present with insomnia associated with snoring and daytime sleepiness and obesity. This is also this is associated with obstructive sleep apnea. The fourth condition, the circadian rhythm sleep disorder, inability to sleep because of mismatch between the circadian sleep rhythm and the desired sleep schedule. And this we find it with people who are working on the shift. Selected circadian rhythm sleep disorder, for example, the delayed sleep phase syndrome, which is a difficulty falling asleep at the desired time. And this one, I had it for a long time when I was an intern. That was a long time ago. When I was intern, and that's why I decided my career I should not be in any specialty that requires on-calls. When I go to sleep maybe after 11 o'clock, I pass by the wards. I say, sister, do you have any problem? I am going to sleep. They say, no, nothing. Alhamdulillah, everything is okay. Please go to sleep. And I go to sleep and I carry 3 bleeps. One personal, one for the on-call, and the third one for my colleague who's going for dinner or for something. So if you have 3 bleeps at one time, surely you will be awake. So difficulty falling asleep at the desired time. I go at 11 o'clock, I want to sleep, but I have 3 bleeps. My mind is linked with the 3 bleeps. This one will ring, this one will bell, this. So I have very difficulty at the beginning to sleep. Difficulty waking at the desired time, this I have no problem with this, alhamdulillah. I can wake up at any time. Number 2 is the advanced sleep phase syndrome. Difficulty staying awake in the evening. And this we can see it with the old people. After Salat al-Isha, they tend to sleep. Waking too early in the morning. This is seen with the old people. We call it advanced sleep phase syndrome. Problems related to shift work and difficulty getting enough sleep during available sleep time. You are required to work at a specific sleep time, especially those working in the emergency room. Every 3 days they change their shift. Every 2 or 3 days they change their shift. Okay, we talk about primary insomnia. When do we call the condition primary insomnia? When other causes are ruled out or treated. Associated factor is the chronic stress, hyperarousal, poor sleep habit, and behavior. This is we call a primary insomnia. What are the consequences of acute insomnia? This includes sleepiness during the day. If he did not have enough sleep at night, he will fall asleep in my lecture. Negative mood, okay? He will be nervous from anything. Impairment of performance, he will not perform his work well. The severity, however, is related to the amount of sleep lost in one or more nights. The consequences of chronic insomnia include fatigue. If he did not sleep for 3 nights consecutively, he will be fatigued. His mood will change. He will be depressed and irritable, difficulty concentrating. And I have one example here, one secondary school student. He was very good mathematics, and he continued the whole night. He did not sleep, and he went to the exam. It is a math exam, and he could not write anything in the paper because he was up all night. He could not concentrate. Impaired daytime functions. These are the classification of insomnia by association of sleep disorder. This is another categorization, psychophysiologic, psychiatric, inshallah. Drugs and alcohol associated, sleep-induced, respiratory impairment, sleep-related movement disorder, syndromes, medical, toxic, and environmental causes were unknown. I know when you see such a slide, you will get fed up. Evaluation, we want to rule out the medical conditions, for example, the hypertension, the hyperthyroidism. We don't label a patient insomnia unless we investigate him first to see he's not hypertensive or hyperthyroid. Psychiatric condition, we would like to rule out psychiatric condition if he has anxiety, panic, depression, and these constitute 30 to 60%. Drugs, if the patient is not on drugs like sedative, hypnotics, or alcohol. Circadian rhythm disorder, of course, we mentioned this earlier. Exercise 30 to 40 minutes, 4 times per week. This is, we are now starting to talk about the management. Moderately intense activity improves sleep. It takes up to 8 weeks before you can see the effect. You ask the patient to exercise as a treatment for sleep, it will take at least 8 weeks before you can see the effect. Alcohol and food, snacks may help the patient fall asleep. Heavy meal should be avoided. So these are the things we should advise the patient before we start any treatment. Drug therapy, if non-drug therapy did not work, then low doses of benzodiazepine, which is not available in our primary health care. Chronic drug therapy is controversial. Some people, they say yes, some say no. Physical dependence is a side effect with long-term use. This is the problem with benzodiazepine. Drug therapy, we have the short and intermediate acting benzodiazepine. These have the advantage of no accumulation with repeated use, the short and the intermediate acting, and no production of active metabolites, and no anxiolytic effect next day. This is the good thing about the short and intermediate acting. They are rapidly cleared from the body. But what are the problems of the short and intermediate? They have moderate rebound insomnia and amnesia. They have mild risk of early morning insomnia and daytime anxiety. This is the problem with the short and intermediate acting. When we talk about the long-acting benzodiazepine, the advantage is that no rebound in amnesia, no early morning insomnia, and no daytime anxiety. But it has another side effect, accumulation of active metabolite on repeated use, slow clearance from the body, which leads to prolonged effect, increased association with hip fracture. They find that hip fracture is more increased with the long-acting benzodiazepine. The acute, our goal in treatment of the acute insomnia is to improve the patient's sleep. When to start treatment is when it affects daytime activity and the duration, with the duration increases of the episodes, and if it persists beyond 1 or 2 nights. We don't want to go into the chronic insomnia. That's why this is our goal of the acute, treating the acute. So in the treatment, the pharmacological treatment, as we said, short-acting hypnotics. Sleep hygiene measures, and we will talk about this. In the chronic, look for the cause and treat the medical or psychological problem if there is any problem. Behavioral take weeks before improvement is seen. This is the problem with the behavioral treatment. The pharmacological is rapid symptoms relief, but it is challenging, pharmacological. Behavior modification in insomnia, this is what we call the behavior modification. First, allow at least 1 hour before bedtime to relax. Then lie down with the intention of sleeping only when drowsy. لما تكون تعبان فقط اذهب إلى النوم. If you cannot sleep, get out of bed. If you cannot sleep, get out of bed. Pray or do something light. Try to get up at the same time every day. You put the clock at a specific time every day, preferably Salat al-Fajr time. Reserve the bed and bedroom for sleeping only, except sex. Restrict the amount. Of course, people here, they watch TV at the bedtime. They eat dinner at the bedroom, which is wrong. Restrict the amount of time spent in bed. Try to go to bed only when you are tired. Limit daytime napping. Some people, they go nap, they go sleep at midday, around 1 to 2 o'clock in the afternoon. Get regular exercise. Okay? These are what we call the sleep hygiene. Behavioral treatment to change maladaptive sleep habit, autonomic arousal, alter dysfunctional belief and attitude. This is a very long procedure. Relaxation method, sleep restriction therapy, stimulus control therapy, cognitive therapy. It's a very long list, and I cannot explain it all this lecture. Okay. Pharmacological, as we said, with the hypnotic, the antidepressant, and the antihistamines, sometimes used as a drug for insomnia. Hypnotic medication, short term, we mentioned the short acting and the long acting. And 10 to 15% are using the treatment regularly for more than a year. Increasing the dose rarely leads to increased efficacy, but increases the side effect. If the patient complains to you that the benzodiazepine you prescribed for him is not doing its job, don't increase the dose. Short acting for important occupation or societal demand. Long acting if anxiety during the day. This is going to use the short acting and the long acting. Contraindication of the hypnotic medication is contraindicated during pregnancy, during obstructive sleep apnea, or if the patient is on substance abuse. Special precautions if the patient has a hepatic disease or renal disease or pulmonary disease. This is some examples of short-acting drugs, Rizolam and Tolbidine. And this is the intermediate. This is the long-acting. I don't want to go too much detail because it's prior time. Antidepressant, little evidence support the use of low-dose sedating antidepressant unless the patient is depressed. Why not? Because of the side effect, you know, the anticholinergic effect, the cardiac toxicity, orthostatic hypotension, sexual dysfunction, and in this case we use the SSRI, and SSRI plus tricyclic for the restless leg syndrome. Periodic limb movement only indicated in patients with psychiatric disorder. Okay. Antihistamines, the diphenhydramine, sometimes used, but is not recommended. Hydroxyzine, subjective and objective improvement during short-term treatment. Long-term treatment is not studied. Side effect, daytime sedation, cognitive impairment, anticholinergic effect, tolerance. Thank you very much.